Hello everyone, this video I'll be talking about photocoagulation in short. I'm reading first chapter from the book Step by Step Laser in Ophthalmology by Bikas Bhattacharya. So in the last video we saw laser tissue interactions which has terminal effect, photocoagulation effect, ionizing effect, terminal effect, photocoagulation, then photovaporization, then photochemical effect, photoablation, and photoradiation, then ionizing effect, photodisruption. In this video I'm not going to talk about that thing because I have already talked about it 2 to 3 times in the last video. So I'll read next. See, this is the page number 4 from chapter 1, lasers in ophthalmology. So I'm gonna read 1, 2, 3, 4 pages in this video, and tomorrow I'll complete this chapter, and the day after tomorrow I can continue with ALT and SLT, that is related to the glaucoma. Photocoagulation. In photocoagulation, temperature of treated tissue is increased from 37 degrees centigrade to at least 50 degrees centigrade, resulting in denaturation of tissue protein and coagulation at the absorbent tissue site. This results from conversion of light energy to heat energy. The monochromatic light from laser is absorbed by melanin, xanthophyll present in the macula, and hemoglobin. So 3 pigments in the retina: melanin, xanthophyll, and hemoglobin. Hemoglobin in the blood vessels. Melanin, xanthophyll, and hemoglobin. So melanin, xanthophyll present in the macula and hemoglobin. Melanin pigment universally absorbs light spectrum between 400 and 700 nanometer, whereas xanthophyll and hemoglobin pigments are selective absorber. Melanin pigment is a principal absorber of light in photocoagulation of trabecular meshwork and co-absorber of light in retinal pigment epithelium, melanosomes, and choroids, melanocytes. The longer the wavelength, the deeper the chorioretinal bones. Hence, argon laser 514.5 nanometer and frequency doubled Nd:YAG, that is neodymium, yttrium, argon, garnet, aluminum garnet. Neodymium, yttrium, aluminum garnet. 532 nanometer laser are absorbed at the level of the retinal pigment epithelium RPE and choriocapillaries, whereas krypton ray 647 nanometer and diode laser 810 nanometer produce deeper lesions in the choroids. The appearance ophthalmoscopic of optimum threshold retinal bone in argon laser and frequency doubled Nd:YAG laser green KTP will be the same and quite different from the krypton ray and diode laser photocoagulation bone. So similar appearing krypton ray and diode laser retinal photocoagulation bone will be markedly of higher threshold and will cause more extensive choroidal damage and pain as compared with argon laser and frequency doubled Nd:YAG laser bone. Longer the wavelength, deeper is the penetration, and hence more pain. Xanthophyll pigment is present in the inner and outer plexiform layers of retina of the macular area. They absorb blue light maximally and green light poorly. Macular area absorb blue light maximally and green light poorly. Hence, in macular photocoagulation, blue-green argon laser will cause unwanted inner retinal damage. Therefore, argon green laser 514.5 nanometer and frequency doubled Nd:YAG laser 532 nanometer green KTP are preferred over argon blue-green laser in macular photocoagulation. Hemoglobin absorbs blue, green, and yellow light considerably, and red light poorly. The shorter wavelength yellow lights are more easily absorbed. The red and near-infrared wavelength lights are totally unabsorbed by the hemoglobin. Lasers which are commonly used in photocoagulation: CW, that is continuous wave green argon laser, 514.5 nanometer, frequency doubled Nd:Arc laser, 532 nanometer, krypton red laser, 647 nanometer, and diode laser, 810 nanometer. Once again, the lasers commonly used in photocoagulation are continuous wave, that is CW green argon laser, 514.5 nanometer, frequency doubled Nd:Arc laser, 532 nanometer, then krypton red laser, 647 nanometer, and diode laser, 810 nanometer. CW green, that is continuous wave green argon laser, 514.5 nanometer. It is absorbed selectively at the retinal pigment epithelium, RPE, hemoglobin pigments, choriocapillaries, layer of rods and cones, and at the outer and inner nuclear layers. It is readily absorbed by the melanin granules. It coagulates from choriocapillaries to inner nuclear layer of the retina. It is suitable for photocoagulation of retinal pigment epithelium, RPE, choroids, and blood vessels. Frequency doubled Nd:Arc laser, 532 nanometer. It produces a P-green beam. It is often termed as green Nd:Arc laser or KTP laser. It is more highly absorbed by hemoglobin, Hb, and the melanin present in retinal pigment epithelium, RPE, and trabecular meshwork than the argon laser beam. It coagulates from choriocapillaries to outer nuclear layer of the retina. It is small and portable like diode laser. It is a solid state and diode pumped CW, continuous wave laser. The aiming beam is usually diode laser, 635 nanometer, maximum 1 milliwatt. Watt. It causes photocoagulation with least energy transmission and shows a considerable safety in macular treatment. Hence, it is fast gaining major market share of posterior segment photocoagulator. Krypton red laser, 647 nanometer. The melanin granules also readily absorb it. It is not absorbed by the hemoglobin and xanthophylls pigments present in the macular area. Hence, it is particularly suitable for macular photocoagulation and coagulation of subretinal neovascular membrane. It coagulates deeper into the retinal pigment epithelium, RPE, and choroids. It has insignificant photocoagulation effect on the vascular system of the retina. It is less absorbed and more highly transmitted to retinal pigment epithelium, so it is able to produce more extensive and deep coagulation of choriocapillaries and choroids. Diode laser, 810 nanometer. It is the most important semiconductor laser. GAALAS, that is garnet aluminum arsenic, 720 890 nanometer. GAAS, garnet and arsenic, 810 nanometer. Direct photocoagulation of microaneurysm is difficult because it is poorly absorbed by hemoglobin. However, it is as effective as argon, frequency doubled Nd:Arc laser in reducing macular edema. It offers patient comfort due to absence of bright flash of light. However, due to deeper penetration into choroids, it may be painful if the intensity of retinal coagulation is not properly titrated or reduced. It is a low-cost, portable, small, high-powered, and versatile laser. Lasers with blue wavelength light should not be used for photocoagulation in following situations. Blue wavelength light should not be used for photocoagulation in following situations. First, in the macular area, and second, in older patients. 5. In the macular area, first, xanthophyll pigments absorb blue light maximally and green light poorly. Hence, in macular photocoagulation, blue light, blue-green argon laser will cause unwanted inner retinal damage. In older patients, the aging lens absorbs blue light much more than other light wavelengths. The shorter wavelength blue lights are also more scattered by aged crystalline lenses, and that's why we don't use blue wavelength light for photocoagulation of the macular area and in older patients. Macular area, because xanthophyll pigment in the macular area absorbs blue light maximally and it causes unwanted damage to the macular area, and green light poorly. That's why we use the green light more for photocoagulation of the macular area. For example, frequency doubled NdR laser. Then in older patient, why we don't use the blue wavelength light? The aging lens absorbs the blue light much more than the other light wavelengths. The shorter wavelength blue lights are also more scattered. When they're more scattered, more energy will be required, and that's why we don't use the blue light for the older patients. First, it is scattered. Second, it absorbs more blue light. So more absorption, more heat production, and more damage to the lens crystalline proteins. So that was all about the lasers in ophthalmology. First 4 pages, not first 4 pages, 4, 5, 6, 7, 8. One page was for that chart, so we have already discussed that thing. Tomorrow we'll discuss influence of opacities in the ocular media upon laser parameter power, gradation of photocoagulation regions, focusing of laser beam, then laser parameters once again, post photocoagulation advice, photovaporization, photoablation, photoradiation we have already discussed, also photodisruption. In short, it is given once again. Then Pascal pattern scan laser photocoagulator, and that's it. It will conclude this chapter. So it will take 45 minutes to 1 hour tomorrow. I'll try to just make it fast and complete it faster so that we can be back to our glaucoma series, that is the lasers related to the glaucoma. First I'm going to talk about ALT and SLT, argon laser trabeculoplasty and selective laser trabeculoplasty. So that's it. Good night everyone. Thanks for listening to me patiently. Bye.